Hi, everyone, and welcome to this other new session of IA 2030 WHO and TechNet 21 webinar series on why gender matters for immunization. This is our fourth session, and the title today is Make Community Engagement and Social Mobilization Gender Responsive and Transformative. You can listen to this session in French. To do so, please select the globe at the bottom of the Zoom window and choose the desired language, French. If you struggle to find it, please do let me know in the chat area. I'm going to say that in French for our francophone friends. Bonjour, pour écouter cette session en français, vous pouvez utiliser l'interprétation. Pour cela, cliquez sur le globe qui se trouve en bas de votre fenêtre Zoom. Le titre est interprétation. Choisissez la langue en français et vous pourrez avoir accès à l'interprétation de cette session. You can already introduce yourselves and tell us where you're from and your name in the chat. I see that some of you have already done it. Thank you very much. It's always nice to see who's with us. And if you have any question during the presentation, please use the Q&A box, which is available at the bottom of the Zoom window as well. Its title is Q&A and QAR if you are French. Please ask your questions at any point. They will be answered at the end of the session. Finally, this session is, as per usual, recorded, and we'll share with you the links to the video as well as to the slides by email. Thank you very much for joining us today, and I hope you'll enjoy this session. I'll give the floor to Stephanie for the introduction of this session. Stephanie, the floor is yours.
Thank you, Alex, and welcome everybody to the fourth webinar in our series. I hope that many of you have already joined us for previous webinars in this series, but if you haven't been able to join, then fear not. All the recordings and materials are available on our TechNet page. We'll share that link in the chat, and it's at the end of this webinar as well. So this is session number 4. Today we're going to be talking about gender responsive approaches to making community engagement and social mobilization more gender responsive and transformative. We have one more webinar after this. So again, if you are already registered for today, you'll receive that information for the next week. But of course, do please feel free to continue to share the links to this registration with colleagues who might still want to catch the next session next week. So let's quickly move ahead, please. So the basis of this webinar series, for those of you who are new today and haven't been on the others, is to go through in a deeper dive some of the content of this guidance document, which was published last year jointly by WHO, UNICEF, and Gavi, focusing on why gender matters for immunization. And in this document, we present a number of different gender-responsive approaches to increasing immunization coverage. And through this webinar, we've been going, through this webinar series, we've been going through a deeper dive on some of these in more detail and presenting country experiences in how they've actually been operationalizing these concepts. So today we're going to be talking about community engagement and social mobilization, which is one of the buckets of approaches covered in the guidance document. Next slide. So to take us through this webinar today, we are joined by 3 excellent speakers. We'll start with an introduction by Lisa Menning, who is one of my colleagues at WHO in the IBB department. She is the team lead for demand and behavioral sciences. Next, we're going to have a presentation by Ketan Chitnis from UNICEF. She's the chief of social and behavioral change. And then finally, we will have Adeline Tumuke from the Infectious Diseases Institute in Uganda to go through some of the research that they've been doing under the 2IL project there around social and qualitative data analysis. So without further ado, we will go to Lisa to start us off.
Thanks so much, Stephanie, for the introduction. And it's wonderful to be able to join this fantastic webinar series So as Stephanie mentioned, here is the outline for our session today. I'm providing just a brief introduction to how we can make community engagement and social mobilization more gender responsive and transformative. And then we will have two country case study presentations, firstly from Mozambique and then from Uganda, on illustrating how through community engagement activities we can help to mainstream work to be more gender responsive in how we invite the participation and involvement of key community members, representatives, and key groups. Next slide, please. So just to provide an orientation, we know that immunization interventions should at minimum be gender specific. And here on this slide, we can see a kind of continuum from those interventions on the left that might be gender unequal or gender blind. And those are the types of interventions that might perpetuate inequalities or reinforce stereotypes between different genders that privilege men or women over the other. And they might ignore the consideration of gender roles, norms, relations, or differences. And these can contribute to entrenching gender-related barriers. Moving to the right here, we can see that increasingly interventions can be gender sensitive, that show an awareness of these norms, roles, relations. And then even more, they can be gender specific. And this is where they can specifically target or be tailored towards specific groups of men or women for a specific purpose to help overcome those gender-related barriers. And even more so, they can go as far as being gender transformative, which really addresses the underlying causes of these gender-related inequalities and really can turn around gender roles, norms, or relations in a way that really promotes equality and can be much more transformative and even sustainable. Next slide, please. So let's take a closer look at some of these ways in which we can make community engagement and social mobilization more gender responsive and transformative. And there are two main areas of action. The first is thinking about just ensuring that gender balanced social mobilization and community engagement teams exist. So from the part of various implementing partners or civil society organizations, those individuals who are reaching out into communities and working with communities, it's really important that they themselves represent a gender balance and that they're working to listen and to understand and address these different needs and preferences of the different representative groups of men and women in their outreach activities. Through these outreach activities, it's also important that the communications and the dialogue and the content of those conversations can also promote gender equality, again, by transforming these attitudes, norms, and behaviors that can really perpetuate discrimination. Next slide, please. Taking a closer look at the various actions that can be implemented to make strategies more gender responsive and transformative, there's a list that's included in the IA 2030 Why Gender Matters Guide, and there are recommended activities for these gender responsive activities. And so examples of these activities include ensuring that there's a gender responsive lens in social mobilization, analyses, assessments, and plans, so that ensuring that in any kind of local data that's gathered, that is sensitive to gender-related barriers. Secondly, we're considering ways in which these social mobilization and community engagement teams can be representative of different gender groups, and that the communications activities can also be sensitive, and that there's equal consultation with men and women, boys and girls in the design, testing, and delivery of community engagement, communications, and related activities that are really designed to invite the participation and involvement and inclusion of these different types of population groups. Next slide, please. And just going a little bit further into this action list, there's a couple more examples. Next is to design immunization materials, messages, and interventions to truly challenge the underlying causes of these potentially harmful gender norms, roles, and stereotypes. So really intentionally and specifically designing these materials in such a way that they portray men and women as equal and active participants. And lastly, thinking about the channels and platforms that truly reach these different groups and address these differences in access. And this is where we really need to have a strong, adequate understanding of these gender-related barriers to uptake. And in the next slide, we'll briefly illustrate a framework that a WHO with partners and experts developed based on 3.5 years of evidence reviews, expert inputs, field testing, and validation. And we've developed this framework which describes 4 main domains or factors that contribute to vaccination uptake. And we call this our behavioral and social drivers framework. And here we can see that we should be assessing each of these 4 domains to have an adequate and complete understanding of the drivers of vaccine uptake. And in brief, these 4 areas are thinking and feeling, which is where we situate confidence and attitudes and beliefs. There are social processes and social norms. Typically, these influence motivations or intentions for someone to get the recommended vaccines. And their ability to carry through with that is then shaped by practical issues. And this is where we situate access, affordability, and availability of those services, in addition to the actual experience on site of those vaccination services as well, and how someone might be treated in that interaction associated with vaccination at the health facility. And so going a little bit further, on the next slide, we can take a closer look at where the gender and equity related barriers are examined through this framework. And the next slide shows that the gender related barriers that can be explored through the use of the tools associated with this framework, and this is where we have a survey and qualitative interview guides for research. These explore these 2 main gender-related barriers. And the first is around the decision-making autonomy and who in the family or in the household has the final say about a decision to vaccinate the child. And the other is about travel and whether the mother or other caregiver might need permission to take the child to the clinic for vaccination. And we can use this as a starting point for further exploration of the autonomy of a mother in decision-making, in traveling, in accessing even funding, a little pot of money to be able to afford that bus ticket to the health centre, for example. And investigating these gender-related barriers are absolutely critical for giving us an adequate understanding of these reasons for low uptake that can be attributed to these gender-related issues. And like I said, we have a survey tool and interview guides for different types of research that can be locally tailored to the context and the needs. So moving on from here, we'll go over to our next presenter. This is Ketan from UNICEF to take us through our example from Mozambique to learn about how they've applied in practice these gender sensitive and responsive strategies to increase uptake. Thank you very much, Ketan.
Thank you, Lisa. Thanks for the wonderful overview. And good afternoon, good morning, good evening, colleagues. Ketan from the UNICEF team in Mozambique, though currently I'm working out of India. So I'm presenting from there. Next slide, please. So just to give you a quick snapshot of the immunization coverage. On the left, you see a bit dated, but it's from the DHS that we have. The last one, the new one will come out only later this year. Coverage of immunization, and as you can see, the darker areas are the ones where there is relatively less vaccination coverage, particularly in the central part of Mozambique. And then to the right, you see the more recent data from the health database SISMA, where it's more disaggregated by districts. And again, you see the orange and green, so you particularly orange and red spots, where the immunization coverage is quite poor, certainly well below the benchmark of 90% coverage as per the estimates that we expect. Also, on top of that, we have seen, particularly during COVID, that there's been a drop in immunization for BCG1 as well as DPT1, and further going down to DPT3 and other vaccines, from about a 90% national average to down to about 67%. And of course, part of it is attributed to the challenges due to COVID in 2020, 2021. But I think there are also other factors, which are compounding to the drop in immunization. So essentially, we are working towards trying to, increase the immunization coverage overall, and then more broadly post-COVID. Also looking at the zero-dose cases, which are estimated to be about 300,000 as of last year. Next slide, please. Then a quick snapshot on gender in Mozambique, just some statistics. So in terms of the UNDP gender index, Mozambique is 127th out of 162 countries, so not faring that well. While, in terms of laws and policies, there is a constitutional equal rights for women, but it's not usually practiced. It goes back to the model which Lisa was saying, maybe partly due to the social processes like norms and customs. There's also kind of a agreed, broadly speaking, understanding that men and husbands would be considered head of households. Most of the time, they're also breadwinners, if not all the time, and that also impacts in terms of decision-making aspects. Again, then the flip side to that is that women, mothers, are seen as primary caregivers, maybe grandmothers as well. But the decision-making lies with men, as I said. Education, there are big disparities in education in Mozambique, both between men and women, across both men and women. The outcomes for education are quite poor, but particularly when we look at women, on average, it's almost 50% of the women are not able to read and write at the optimal level. And when we disaggregated that between rural and urban, I think it's worse, off to about close to 75% in rural areas in terms of illiteracy rates. Gender-based violence, broadly speaking, is high. And I think that also has a lot of impact in terms of health-seeking behaviors, autonomy, decision-making, etc. Child marriage is particularly high at 53%, and I think that also impacts, younger women having children at an age younger than 18, and that also essentially makes, I think, quite a bit of challenges when it comes to immunization, health-seeking, and other areas of social services. Broadly speaking, also lack of economic prospects, across the country, and worse off for women and adolescent girls, and a lot of unpaid work, which doesn't get appreciated. Next one, please. In terms of looking at gender barriers to immunization, I think there were many. I've just chosen a few which were documented in the case study that we are presenting here. So, distance to the health facilities can be quite far, in particularly the remote parts of the country, which are sparsely populated and fewer health units, across the communities, and they're also very crowded. And that deters sometimes also men from joining or accompanying their partners to go for immunization, because there's a push from the government side to actually get more men to get engaged in overall health of the child, but including for immunization. But there are all these other exacerbating factors which tend to dissuade men from going, and a lot of issues around distance and time at the facility is linked to waiting times and loss of wages, particularly for men. Also, women, tend to lack confidence, and there's a power imbalance in terms of the negotiation powers with regards to vaccinating children. Those have been identified through some of the surveys and the qualitative data that's been collected over the years. Also, there is an issue at the service provision side, where, so most of the time the mothers would take the children for vaccination, and then the vaccination teams require them to come very early in the morning, at about 7 in the morning or even earlier, and they have to wait a long time before actually the clinic opens. But then for some reason, if they're late or they forget the immunization card, they get chastised, by the health workers, which is also a big deterrent. And there's again a power balance, with a male health worker, not talking with respect to the female or to the mothers who bring the children, and that also has impact in terms of continuation and completion of routine immunization. There is also some level of mistrust that has been identified by men, because women are spending too much time at health centers, and then that leads to kind of marital discord or some kind of gender-based violence, which I was saying is also quite high. In some instances, we have seen that men are willing to take children to be vaccinated, but there is peer pressure and their peers making fun of contributing to the well-being of the child, which is changing, as you will see going forward. But that's also one of the factors with regards to gender and immunization. And then not specifically gender, but children with disabilities more broadly, and also those with girls with disabilities tend to have further challenges when it comes to completing routine immunization. Next slide, please. I'll try and rush. I think this is the intervention that we studied for this case study. I won't go into it in detail in the interest of time, but it started in 2014, called the Model Families Program, which is part of the National Health Promotion Strategy, and we've been supporting that through the Ministry of Health. In terms of expanding that health promotion strategy with the Model Families Program as the core. And as you can see, it's almost 10 years now when we are looking at scaling up this approach, and immunization is one of the key behaviors. Next slide, please. I think you may have to click it one more time. Yeah. So the Model Families Behavior Program has 10 domain behavioral domains, which are primarily around the well-being of children under 5. Also goes a little bit further when it comes to school enrollment, but mostly focusing on health, nutrition, hygiene, water sanitation, and also protection in terms of birth registration and education in terms of school enrollment. And the health card, the child health card, which is what is key with regards to recording immunizations, is one of the key behaviors that is promoted through this program. And when we did this case study, we used the model family as a lens to try and understand how this whole program is contributing towards addressing gender barriers across adoption of behaviors, particularly around immunization. So next slide, please. So what we found with regards to gender issues in immunization, and more broadly within the role of gender when it's addressed through the Model Families Program, which is essentially rolled out, by community health workers, which are in Mozambique, complemented with the health workers or volunteers from the community, including the community health worker, plus other men and women that are promoting the key model family behaviors. And then we are reinforcing that with community and local media and outreach platforms, so as part of the community engagement, social mobilization, to reinforce behavior change. So that's the program in a nutshell. So over here, what we found was that, and this was done based on analysis of secondary data, as well as some interviews which were done as part of this documenting this case study. So we found some indications of gender equality that were evident as part of women who were part of the families that, and the mothers of those families who were part of the Model Family Program, were in terms of sharing burden of childcare, which because was promoted through the health committee members and the other platforms. Women being part of health committees was actually empowering. It gave women a voice, ability to talk and dialogue, with the health workers, with the community leaders, And I think that made a difference in terms of also having some say in decision making, in terms of care seeking, in terms of ANC, as well as immunization. Monitoring reports also indicated that there have been instances of husbands, men bringing children to vaccinate, the families that are part of the model family, which were tracked at the health centers. Also, as I said in the previous slide, there is this issue of men wanting to change or men wanting to get more engaged in childcare or child rearing practices, but they were feeling chastised by their peers. That was changing among the younger generation. I think, as you can read from the quotes to the right, I think the more younger parents or men were feeling a bit more confident to change and get more engaged. And there were also some instances where women themselves were resistant towards having both, they and their husband go to the health facilities, and usually men were taking children for immunization only if the woman couldn't because she was unwell or for some other reason. So these are some of the kind of snapshot of the key findings. Next slide, please. Recommendations that came out of this case study. This is a package of, we've done 6 case studies through the UNICEF team in New York. So Mozambique is one of them. And the recommendations I'm presenting are quite specific to Mozambique, but some of them are also recommendations that have been made, through the report of this, the case studies, which are a bit more broader to other countries. So what we are suggesting is that for Mozambique, it would be important to extract data from the vaccination cards of model families to better understand, the attribution between the model families initiative of promoting all the behaviors, including routine immunization, and then trying to address those gaps. So if we see that the parents that are part of the model families are not necessarily bringing their children for vaccination, then we could maybe understand the reasons behind that. And given that the data for vaccination or immunization in Mozambique is not disaggregated at the national level between gender for men and women or boys and girls, I think this would be another way for us to extract from the vaccination cards to understand a bit more gender-specific variations if they exist. We're also recommending that some specific indicators be included around power, agency, decision-making, these kind of indicators in the model families monitoring tool that we have, which is right now only looking at observable behaviors of, on those 10 domains, but we could have these social behavioral kind of indicators included, which can be routinely collected to understand changes in gender and immunization. Also suggesting very specific indicators on male engagement. So, simple ones like number of fathers who actually bring children for ANC or PNC or vaccination. Also proxy measures in terms of, sharing of household work within, including, childcare responsibilities, or others like, related to hygiene, sanitation, those which would be relevant for those domain of behaviors which would impact child health. Impact of vaccination based on gender of the child, I think it needs a bit more analysis, as I said, because we don't have data in terms of girl children who are versus boy children who are, the gap in terms of vaccination, if it exists, and so why. So I think that's something that we can also further do with regards to this data. And as I said, I think the interpersonal communication between health providers and the caregivers would be important to improve so that, women are treated with respect by the male care, the health workers, as well as promote maybe more gender equitable roles around immunization as part of that package that happens between service providers and caregivers. Next slide, please. I think that's the last one. Yeah, so these are the resources. So these are the 3 package of documents that UNICEF developed, I think last year and published this year. Guidance in terms of the gender and immunization. There's the case studies, and then there is the checklist of what could be done to improve demand for immunization. So I think these UNICEF colleagues can provide you, or they are available at the website. I'll pause here in the interest of time and be ready for any questions. Thank you, and back to you, Michaela. To Adeline, actually.
Thank you so much, Keita. It's really a pleasure joining today's webinar, and I would like to take this opportunity to welcome you all participants once again. So today I'll be presenting about community engagement to mainstream gender vaccine introduction in Uganda, a rapid community assessment approach. Next slide, please. So this is the focus of the presentation. I'll give some definitions regarding community engagement, present an overview of the rapid community assessment, the RCA, and also discuss application of the RCA to engage community and inform gender responsive strategies for immunization. So community engagement is a process of working collaboratively with and through individuals, groups of people, communities, in order to address issues that affect their interests. So Uganda introduced the second dose of measles, rubella, MR2 vaccine in October 2022 per the WHO recommendation. However, the introduction of MR2 in the African region has shown slow progress, achieving optimal coverage. So in Uganda, the gender barriers to immunization are not well studied, but gaining recognition and prominence to assess and address. So the RCA was conducted prior to the MR2 introduction to simply get a quick insight about caregivers' knowledge, perceptions, and healthcare workers' readiness to be able to inform potential programming and the preparation for the initial rollout of MR2. Next. So community engagement runs along a continuum, and it is very important to involve recipients of strategies that support immunization during the design of vaccination interventions. So it's important to engage with the marginalized and also the difficult to reach communities. So for the case of our RCA, we may not have started at the beginning of this continuum, but in future we may aim to move through the further levels, as this slide shows. So our focus, like I mentioned, was prioritizing meaningful community insights prior to the rollout, and the findings suggested that community engagement was actually very important going forward. So within the RCA, community engagement was actually manifested in the outreach layer, where we involved the community at the pre-RCA level. And what happened here is that we conducted community mapping after consultation with a couple of relevant stakeholders. For example, we made formative consultation with partners like UNEP, Ministry of Health, to be able to identify the priority areas for MR2, and for also Ministry of Health to grant us permission to conduct this rapid community assessment. So when we look at the consultation, it occurred during the RCA implementation. So we were able to conduct surveys among healthcare workers. We conducted focus group discussions with caregivers, key informant interviews with community leaders. Some of them were VHTs, village health teams, others also were district health officials. So in that whole process of our RCA, we were able to involve both the male and the female. And you notice that women are often the frontline workers who are engaged in vaccination in most settings. And they are the primary caregivers or caretakers of children. And that means that most often they are the ones who take children for vaccination. Next, please. So we had 5 phases of the RCA, where we had the preparation, planning, collected data and analyzed data. We identified solutions, reported findings, and also had evaluation efforts. So it is very important to consider gender equity throughout the assessment process. Next, please. So in terms of preparation for the RCA, we used gender consideration for the specific stages. And one of the most important elements of the RCA is to identify the primary objectives. This can be helpful to formulate gender objectives as a question. And this can be answered actually by the community you are working with. And once you have identified your focus community, you rapidly review the existing data sources, get a picture of its demographics, the health status, and how individuals are impacted by the vaccine preventable diseases. Next. So in the step 2, this is regarding the disaggregation of data, which is very important to be considered by gender and additional factors. For example, age, ethnicity, socioeconomic background, and disability. It is also important to identify focus people in the community who are invested in implementation or outcomes of immunization programs. For example, individuals with considerable authority who have influence on community opinion, and this can be by virtue of their roles, their status, their knowledge, their reputation, and the whole essence is to get their buy-in. So I can give some of the examples of the leaders or the individuals that could be involved. And in our case, we were able to involve local leaders, leaders of local health systems, for example, hospitals, clinics, religious leaders, populations that are affected by inequalities. And it's also important to consider outside organizations or partners. For example, the local community-based organizations, the academic groups, health facilities. You could also consider youth groups. And this is very important because it's important to consider the gender balanced social mobilization. And this also applies to the data collection team. There has to be an appropriate participatory method for collecting the data to ensure that there is meaningful participation, not only for the men and the women, but even the team that is involved in the data collection. It's important to ensure that it's a form of gender balance. So it's also important to ensure gender inclusion during assessments. And these assessments could be conducted using a couple of methods. For example, you could choose to use quantitative methods, qualitative methods, observation, or you can use a mixed method where appropriate. And again, in all this methodology, the ideal assessment team should include both men and women, and these individuals should actually be committed to understanding and addressing community needs that regard vaccination. And it also has to have varied background, skills, and experience, if at all we are to engage meaningfully. Next slide, please. So This diagram shows how we planned for the RCA. We used the convergent mixed method approach among caregivers of children aged between 12 to 59 months. We also interviewed healthcare workers and community leaders in 18 districts in Uganda. So the setting was based on the UNEPI measles 1 vaccination coverage. That is 8 highest coverage districts, 8 lowest coverage districts, and 2 districts with recently confirmed measles outbreak. So, and the essence of that was to draw inferences regarding the barriers and facilitators, and to be able to come up with interventions that are gender responsive. And in terms of gender responsive programs or policies, this is where the gender norms and inequalities have been considered and measures have been taken to address them. So they go beyond gender sensitivity, and they may include gender specific as well as gender transformative action. Next. So when you are collecting and analyzing data in this step 3 of the RCA, make sure you hear the voices of women and girls. Women and girls are not usually a homogeneous group, so make sure they are well represented so that you're able to capture information about the subgroups as well. And when you're analyzing such data, they segregate women from men to identify any differences, not just in the outcomes, but in examining differences in any barriers to immunization. So there are some of the ideas that could be helpful in terms of recruiting participants for data collection. For example, you can aim at least having 50% of response from women. You could choose meeting places that are convenient for women, hold separate listening sessions for men and women, and this will help to ensure that women's voices are heard. You also need to obtain a buy-in from the gatekeepers of women. For example, the husbands or the mothers-in-law. And when it comes to intercept interviews, sometimes you may need to go to places that women frequent, such as salons, marketplaces, so that you're able to capture information regarding a particular issue. So in terms of data collection tools, you need to consider them as well if you're trying to bring in gender issues, because you have to make sure that the survey questions about employment are captured. For example, include options for the many roles that women may play. For example, informal work, child care, farm labor. Include as many employment options. You also need to include on your team women, like I said, because depending on the local cultures, some people may prefer to speak to women, or they are not permitted to speak to men during an interview. So this too has to be put into consideration. So in terms of using intersection gender analysis approach, that identifies and addresses the interaction of different social categories and power hierarchies that results in health inequities. So you also need to think about that. Next. So this diagram shows the multi-level gender-related barriers that are related to MR2. Our RCA did not set out to explore gender-related issues directly, but the gender barriers were strongly highlighted in the discussions, especially with the community participants, and basically the focus of these findings. So this diagram shows the various socio-ecological levels in which gender barriers operate, and the green bolded text refers to the findings from our RCA. So because of time, I will not go into details. However, I'm going to pick up some of the key issues that arose from our finding. So one of the issues that arose was about women caregivers who reported having less decision-making power than men. There was also an issue where women who might not have income-generating activities were financially dependent on the child's father to provide the resources in order to be able to access immunization, but they found it a challenge if men lacked finances. There were also gender norms and role differentiation among the men and the women, and these were also found to influence vaccination. So childhood vaccination among women was also reported to be done along juggling household responsibilities, for example, cooking, caring for homesteads, which kind of became a barrier in terms of accessing vaccination. There was also the issue of low male involvement in child's vaccination that was reported, although few participants said some men were actually involved in child vaccination. And some concern among the women was that whenever the men appeared in a health facility for child vaccination, they would be offered preferential treatment, and women were concerned about that because they felt they were being treated differently. So in terms of strategies that were suggested for scaling out MRA2, they were mainly community-based interventions, for example, the family-based approaches, the peer-to-peer interactions. All these were suggested to improve MRA2. Next slide, please. So in this step 4, it's about identifying solutions, and this can be done by answering strategic questions. And it's very important to map the gender responsive solutions to the gender barriers. And in terms of it's important to even consider what has been effective in a particular community may be comparable to other settings. And this, yeah, next, click, please, click the next. Yeah, and this will offer effective solutions. For example, in terms of increasing trust in vaccines, establishing vaccination as a social norm, motivating people or encouraging them to get vaccinated, and also improving the physical access to vaccine. Next. So in terms of recommendations, the key recommendation here is that gender can be integrated in all phases of the RCA or some particular phases. However, there is need to consider mixing opinions from women, even when it comes to disseminating of results, for example. So our findings showed that community engagement should be a key component of vaccination intervention. And of course, the suggestions given by the community leaders and the caregivers were in terms of involving women groups, engaging with men to address vaccination decision-making and seeking. And therefore, we have come up with a peer-to-peer gender-focused approach. For example, through mother-to-mother peer support groups, peers can share vaccination experiences that could increase immunization awareness. Next. So in terms of reporting findings, it's very important at this level to tailor your report to the needs of the audience. Consider, first of all, the importance of language and the potential responses that could be easily criticized. Leave time for stakeholders to also give feedback on prioritizing strategies. Next. It's very important in this 5th stage for you to evaluate your efforts. And this, you could do it by engaging women leaders, to understand if the gender barriers are reflecting what is seen in the community, and to also leverage community relationships to inform continued planning, piloting, implementation or evaluation. And you could also nest gender focus within a larger intervention approach. Next. Finally, these extra slides are about the resources that can be helpful in terms of immunization and gender. You can refer to those. Next slides. The other two slides are about examples of questions that could focus, for example, objectives in a gender-related manner. So these are some of the qualitative questions. You could explore the potential issues, for example, that could hinder taking children to health centers. You could explore decision-making in terms of child vaccination, who makes it, if there are additional doses, what are the roles of men, what are the roles of women, and as well as the ease of taking them to the health facility. Next slide. And these are quantitative questions, just a sample that could help you ensure that there's gender consideration in an assessment or an RCA or in a survey. So I would like to stop it here because of time. And I'd like to specifically thank you for being present in this webinar. And I'm looking forward to the questions and the future webinars. Thank you. I want to hand it over to you, Stefan.
Thank you so much, Adeline. And actually, just because we're really running out of time, we'll whip very quickly through some of these questions that have already been posed in the chat and the Q&A box. But I know these presentations were so rich and detailed. So yeah, we have to balance providing all the content with time for Q&A. But just to you, Adeline, before you disappear, I do see that there was a question about whether this will be published anywhere. Are you planning to publish, or is this available online? For those
actually, we plan to publish in September. We've already in nearly finalizing the manuscript. It will be out soon. Thank you.
Excellent. Thank you. So just looking quickly at some of the questions that have been posed in the chat. So I thank you, Lisa, for already going ahead and answering some of them. But maybe just to Ketan, it would be great if you could share wider information on the model families approach in Mozambique. So if you can maybe address that in a 1 to 2 minute response. And just while Ketan is getting ready, I do see that there are a number of questions and comments around focusing on men as well. And even in the chat, I see that one of our Nigerian colleagues mentioned that in the context of Northern Nigeria, men have overwhelming decision-making and economic power. And so I do actually think that some of the content today did speak towards that. But just to remind everybody that our webinar next week will be focusing specifically on the role of engaging men and families in general in family-wide decision-making for health and immunization. So we'll be able to go into that specific angle in a little more detail next week. So Ketan, over to you just to elaborate a little on the model families before we end.
Okay, thank you very much. I will try and share that also as resources to be put on the website maybe. But very quickly, it's really about the term, like having a family which is practicing key behaviors which would be helpful for the well-being of their child. And this is part of the National Health Strategy, Health Promotion Strategy. Started with the implementation in 2 provinces in about 7 districts of those 2 provinces, so kind of small, and slowly it's expanding. And of course it needs resourcing, so we are supporting it as much as we can, and some other donors as well. And the point around model families, of course, it's promoted through a lot of community platforms, through taking into account all the local kind of cultural factors. Using influencers, using traditional healers, using religious groups, local media, etc., etc. But the point about which is interesting is about certifying the model families using the district authorities. And that certification process is based on observable behaviors that can be essentially seen when you go to that household. So essentially, all the communities are triggered for these practices, and then a randomized set of 10 families is chosen in a locality. And even if one of them is not practicing 80% of those 13 behaviors, then we go back and do the promotion again till everybody in that community is adopting those behaviors. And those 10 domains, as I said, from health, immunization, hygiene, sanitation, primarily, those are the ones which are covered. And birth registration, which is a little bit outside, but I think very relevant. So I'll share that with you. And immunization is one of the key behaviors within that model family practice. Over.
Thank you so much for that. And I think we just maybe have time for one more. And so maybe Lisa, I see that you typed an answer, but just maybe worth sharing with everyone. So Nessa had a really good question around, community engagement to potentially counteract resistance. And, I think this is obviously something that extends just beyond the gender issue, but, more broadly to immunization in general. And so lessons can certainly be learned. Maybe you can just read your answer out loud and elaborate. Thanks.
Yeah, for sure. This is a really interesting question. And I would say that the first step is actually to better understand the reasons for this resistance. So why does this resistance exist? Who's it coming from? What do they want to achieve? As well as who's actually paying attention to these individuals or groups who are being kind of bad actors and responding in a negative way to any types of strategies or activities to promote more gender responsive strategies. So the first step is understand what's going on and where it's coming from and who's listening. And then secondly is to involve communities themselves, involve those community representatives to be part of the design and implementation of appropriate strategies to respond to that resistance. Of course, depending on the resistance, we also do not want to get into a debate. Sometimes we don't want to pay more attention to negative information or bad actors who are perpetuating really counterproductive and damaging actions that could be harmful. So we definitely need to be strategic about how we respond in such a way that actually does not give them more attention and does not result in debate and in fact inflaming and adding even more oxygen to the situation. So it does require a little bit of investigation and then a really sensitive and appropriate response that does involve the relevant community actors themselves. Thank you.
Thank you, Lisa. And so I think we're going to end there because we're going to lose our interpreter at the end of the hour. So I just wanted to thank all of our presenters again for the super interesting presentations and contributions today. And thank you to our audience for all of your comments and inputs. I think most of the questions have been addressed, but of course, if there are any other questions, you can always feel free to reach out to any of us through the TechNet platform. Alex will make sure that the questions arrive where they're supposed to. So there's the link to where everything is available for the future sessions as well as the past ones. And so we hope to see you all again here next week, July 20th, same time. It will be our final session in this webinar series. However, we are considering doing a part 2 in the fall. And to inform the planning of that, we are going to be sending around a questionnaire survey to you all. We'll mention this again on the next call as well, to seek your input as to what you enjoyed and what you would want to see on a part 2 of this webinar series. So thank you again to the TechNet team for logistics, and thank you again to Michaela Manna for coordinating this webinar series. That's it, and we will see you all next week. Have a great Thursday.
Thank you. Have a nice rest of the day. Bye, everyone.
Bye, everyone. Thank you.